I'm very pleased to be speaking with you today about the use of COVID-19 vaccines because there are quite a few confusions out there about what's really possible with these vaccines. And I thought it might be useful to talk about lessons from the control of other vaccine preventable diseases and the eradication of smallpox and polio to give a context to the current vaccines. So vaccines have been used for disease control since they've been developed. And this is a non-specific term for reduction of disease incidence, but continued vaccination must be accomplished. And this is the WHO guidelines for routine vaccination, which is a vaccination process which must be continued throughout a child's life course. Here you can see the effect of these vaccines because this is a bacterial vaccine for pertussis. It's a toxoid. And what you can see at the top is WHO, UNICEF estimates of vaccination coverage, reported coverage by countries in blue, and then the number of cases, which has clearly decreased. In fact, if you ask clinicians today, very few of them have had to treat pertussis using an antibiotic. So the benefits of using vaccines for bacterial infection control are decrease in morbidity, mortality, the decrease in use of antibiotics, and the decrease in hospitalization. Vaccines are also used for elimination of transmission, and a viral vaccine shows this best, the measles vaccine. What elimination is a reduction of 0 to the incidence of infection caused by a pathogen in a country, but there still needs to be continued surveillance because the disease exists elsewhere and could reinfect a country. So the WHO program on measles elimination is a program which requires continued routine immunization, but in addition, the conduct of vaccination campaigns before the season of high transmission. And again, as you can see for this viral vaccine, WHO reported estimates of coverage in red, country reporting in blue, and then the decrease in disease that's occurred in this viral infection. And this, like bacterial infections, is very useful means of using vaccines. However, all vaccines are very threatened by false information, and this shows you false information about measles vaccines causing autism, which was in the Lancet, and which caused a huge anti-vaccination movement around the world. And as you can see, measles has been very difficult to control since these rumors have been out in public. And there are monitoring systems, such as in Europe, which give an indication of when rumors are important to observe, because they've seen here that there's an increase in requests on the internet for a disease when an anti-vaccination movement against that disease has occurred. But even so, bacterial vaccines like viral disease decrease mortality, decrease morbidity, decrease the use of antibiotics for superinfections, decrease hospitalization, but they, like all vaccinations, are sensitive to anti-vax rumors. Vaccines are also used for disease eradication, and this is the permanent reduction to 0 of a specific pathogen and no possibility of reinfection from nature. Now, smallpox is the classical disease that has so far been eradicated, and there were certain characteristics of this which made it able to be eradicated. First, the vaccine was heat stable, but it also provided protection against infection, lifelong protection against infection. Clinical diagnosis was easy because every infection was clinically expressed. Transmission was face-to-face by droplets. Immunity was permanent after infection, and there was no animal reservoir, only humans. So, with a vaccine that was available back in the 1960s, a massive eradication program began. The vaccine is shown here. The bifurcated needle, which was used to vaccinate, is shown here. A very easy process of putting a drop of vaccine on the skin, laying that bifurcated needle on the skin, and then puncturing through that vaccine 20 times into the dermis in order to vaccinate. But this vaccine was associated with death and permanent disability because the vaccine was not a pure vaccine. And so there was associated death and permanent disability. But even so, it was decided that the risk from naturally occurring smallpox was less than the risk from vaccination. And so the vaccine was used in an eradication program. That would be very difficult to do today, but it was done back in the 60s. And the program was very simple. Identify people who had smallpox, remembering that each infection is clinically expressed, isolating those persons, and then vaccinating their contacts and 30 households around where they lived, or the apartment floor above and below where they lived. Very successful program, costing US $300 million during the period of time when it was done. This was external funding coming into countries. And the US calculated that because they didn't have to vaccinate on a regular basis anymore, they saved the equivalent of their investment in WHO smallpox eradication every 26 days. So what happened with smallpox was it disappeared from the face of the earth, except it's in a couple of laboratories still, but it's not in nature in any way. And so what you can see is that the smallpox deaths estimated in 1967, which were about 2.7 million, would have been extremely high today if that had been escalated. But even more important, even if you compare the 1967 deaths to deaths occurring from AIDS, TB, acute respiratory infections, diarrhea, and measles today, and malaria, you'll see that it was really a major killer gone from the world. Now, polio vaccination is also an effective tool, and it does cause lifelong immunity. But polio eradication didn't begin until 1988. And again, there was no reservoir in nature, an easy to administer effective vaccine with lifelong protection, and the feasibility of eradication had already been proven in industrialized countries. But this was a different infection from smallpox, because whereas smallpox, every infection was clinically expressed, in this infection, only 1 per 600 to 1,000 infections were clinically expressed. So even though asymptomatic infections caused lifelong immunity, the strategy had to be different because of the number of asymptomatic infections. So the first strategy was routine childhood immunization, continued in countries. The second was a surveillance system of laboratories around the world, constantly isolating the virus, providing it for genetic sequencing to reference laboratories, and using that information to determine where polio was occurring and also where it was traveling because of its genetic sequence. At the same time, there were mass campaigns that had to be done in countries to effectively make sure that herd immunity was obtained from smallpox. And we'll talk about herd immunity in a bit. But smallpox eradication ran into a problem in 2000 when it was realized that the vaccine being used to eradicate polio was also causing vaccine-derived polio because the vaccine strains of Sabin live virus were not stable. And so there was a major outbreak of polio in Hispaniola back in 2000, 10 years after Hispaniola had been certified free of polio. This would turn out to be circulating vaccine-derived polio virus, either through recombination or reassortment. There was a greater than 1% genetic difference from the parent strain. And this occurs, we know today, in areas where there's low polio vaccine coverage and weak surveillance. In fact, this is the picture of polio eradication today. 2 countries still have wild polio virus 1, and you can see those are Afghanistan and Pakistan, the red dots. Several countries have circulating vaccine-derived polio virus type 1, and that's in Madagascar and Réunion, and you can also see in the Arabian Peninsula. At the same time, you can see that there's a severe amount of vaccine-derived polio circulating within Africa, making it almost endemic in some parts of Africa. So there's been a need to change the vaccination schedule. Trivalent oral polio vaccine was withdrawn. Bivalent oral polio vaccine 1 and 3 continued to be used. And you can see the schedule that it was used in, along with inactivated polio vaccine. But even that has continued to spin off vaccine-derived polio. And so now there is a new oral polio vaccine made from a stabilized Sabin strain, which is genetically stable and provides comparative immunity against poliovirus. And so this vaccine is now being used in countries where circulating vaccine-derived polio continues to occur, as you'll see on this slide. So the benefits of eradication are clear. No morbidity, no mortality, no use of antibiotics for superinfections, no hospitalization, cost beneficial, but this may require a continuous innovation in vaccines, as we've seen with polio eradication. Now, these were all based, eradication programs were all based on herd immunity concepts. And the herd immunity concept is very easy to understand, but it's very misunderstood by the press and has been understood by modelers as well. So let's talk a little bit about herd immunity concept. What you can see here is at the top, a person infected with a virus that has a reproductive rate of 4, reproductive 4. You can see that for every infection then causes 4 additional infections, whether it's first generation, second, or further generations. And so it amplifies the transmission. If, however, with a reproductive number of 4, there are 3 people immune, as at the bottom in blue, and only 1 person susceptible, you can see that does actually decrease transmission and cause a herd immunity effect. Now, herd immunity is defined as the indirect protection of susceptible individuals from infection when a sufficient portion of the population is immune, and that means immune against infection. The herd immunity threshold is the point at which the proportion of a population that is susceptible falls below the level needed for transmission. Again, the portion of population that's protected against infection, or not against infection. So what you see here is reproductive numbers at the bottom. You can see that for rubella, it's between 5 and 10, and for measles, it's between 12 and 17. And what you can see is that there are vaccines that cause permanent immunity against infection. And when that occurs, if you get a level of vaccination coverage above 90%, you can actually eliminate the infection because transmission stops. But that's with a vaccine that causes protection against infection. Let's talk a little bit about some general concepts of herd immunity, because these are important to consider as we begin to talk about COVID-19. First of all, natural infection generally provides a herd immunity effect, but the duration of that effect depends on the duration of protection against infection. And unacceptable levels of morbidity and mortality may occur while that natural herd immunity develops. Strict non-pharmaceutical interventions decrease the ability to create herd immunity from natural infection. So countries that have locked down at any point during the COVID pandemic, for example, have not permitted natural infection to develop. They have indeed decreased the levels of morbidity and mortality, but they haven't been able to create that natural infection which causes permanent, or which causes immunity, an immune effect. At the same time, vaccination with long-lasting immunity is the most sure way of attaining and sustaining full herd immunity effect with a decrease in morbidity and mortality. Now, there's great confusion in the press and even among some public health communities about what COVID vaccines can and cannot do. And if you look at the left of this screenshot from a recent WHO meeting, what you'll see is that protection is occurring against severe illness and disease in using all the vaccines that are available against variants. But what you can see is that those vaccines on the right don't cause 100% protection against infection. And that protection against infection decreases with variants that are occurring. So moving on, estimating herd immunity thresholds has been a very popular topic for many modelers, and various models have shown herd immunity threshold for Sars Coronavirus 2 to range from 50 to 70% of the population. That's assuming, however, that infection provides lasting protection against reinfection and that vaccines also provide that protection. So which strategy should we be using for COVID-19? Control, elimination, or eradication? Well, there are constraints in attaining herd immunity for SARS coronavirus 2 because there's uncertainty about the immune response after naturally occurring infection. We don't understand the risk of reinfection. We do understand that it can occur. And we do understand that there is protection against serious illness upon reinfection, but we don't know the duration. At the same time, there's uncertainty about the characteristics of vaccine protection, the duration of protection from serious illness and death after vaccine. We know that it's continued during the 9 months of use of those vaccines, but how long will this continue? And will these vaccines protect against infection? We know that they don't protect against infection, and we don't know the duration of the protection that they do offer. So there are many questions in using SARS coronavirus vaccine as a herd immunity effect. And we've seen what happens when herd immunity effects develop in a country, such as in Sweden, which was not using vaccines because they weren't available. And they decided to see if they could develop herd immunity by letting the virus enter in a controlled manner. And so what you see is on the left, what's called the Stringency Index, which was developed in this research paper. You can see that the Stringency Index was lowest for Sweden, the green line, but at the same time, you can see that they did have severe number of deaths because this disease is not equally, the deaths are not equally distributed among populations. They're distributed among those people who have severe comorbidities, elderly, or obesity. So their attempt at creating herd immunity when they didn't have vaccines cost them serious illness and death. But now with the use of vaccines, Sweden, like other countries in Scandinavia, has decreased mortality greatly. So what about the variants? Well, if you look at this slide, you'll see the 4 variants of concern on the left, and on the right, you'll see their impact on what's called vaccine efficacy. But this really isn't vaccine efficacy because we don't know the real correlates of protection. And what this is looking at is the neutralization in a laboratory by sera from persons who were vaccinated. But you can see that if you use antibody as an efficacy measure, neutralization continues in all 4 of those with a slight reduction for some variants. Looking at estimates of the health metrics group out in Seattle using available data and vaccine efficacy, if you look in the second column, you'll see efficacy at preventing infection compared to the efficacy of that vaccine when it was studied in clinical trials. And in the last column, you'll see efficacy at preventing infection coordinated with what was done beforehand. What you can see if you look at the top line is a vaccine that had 92% efficacy in preventing illness, serious illness and death, with an ancestral vaccine, had an 80% chance of continuing that with the new alpha variants. With the delta, gamma, and beta variants, 90% continued to have the same effect, but 78% with the beta, gamma, and delta. So you can see that there is a difference in slight difference in preventing severe mortality and morbidity, but in protecting infection, there's an even less protective effect, and some of those protective effects are lost with these vaccines. So what do we do? Well, we need to do global surveillance for the variants, and there's a good model, and that's the influenza model of WHO, which has over 120 laboratories around the world. Those laboratories are taking clinical specimens of persons with infectious-like illness, about 200,000 a year. They're making sure that those viruses that are influenza are sent off to collaborating labs for antigenic characterization. There's provision of these vaccine viruses for vaccine development, and there's a development of diagnostic tests that are provided to countries. This shows you a schematic diagram of the 3 influenza viruses in humans today. You can see that there's a stepwise progression as you go horizontally across these graphs, which represents drift in the virus. You can also see that 2 new viruses, their major shifts, entered human populations in the 1960s and 1970s, and they've stayed within people, and they're having that same drift. So that network is necessary in order to provide information for vaccine developers each year. And at the top here, you can see a photo, which is a photo of the meeting in Geneva each February, where manufacturers and where experts in virology and influenza sit together and decide what strains need to go in next year's vaccine using the genetic data that's available. This meeting also occurs in the Southern Hemisphere in Melbourne in August. The network is also very important for novel influenza coronaviruses, and this is influenza viruses, and this is the network that determined when H5N1 was actually occurring in humans. And so you can see that this network, working also with networks on animal health, has been able to show that H5N1 avian influenza is endemic in poultry in countries where there's a red, and then dark red shows that it occasionally occurs in humans, especially in Asian countries. And this data is all stored on the GISAID database, which provides a platform that can also be used for coronaviruses and is being used for human coronaviruses. So there are solutions to global surveillance by linking global surveillance for coronaviruses with the influenza network, but making sure that countries have the sequencing capacity they need to rapidly sequence the virus. So there have been some articles that talk about eradicating SARS coronavirus 2, and I'd just like to go through what happened with smallpox and polio to try to convince you that these articles are really misguided. So for smallpox, there was a vaccine that was heat stable and provided lifelong protection against infection. For coronavirus, that does not exist yet. Hopefully, there will be a vaccine one day that can prevent infection lifelong. Clinical diagnosis for smallpox was very easy. Every infection clinically expressed. That's not the case for SARS coronavirus 2. It doesn't express itself in all persons. In fact, there are many, many asymptomatic infections. Transmission, however, mainly face-to-face, is the same. But immunity is not permanent after natural infection. We know that. There's no continuing protection against infection. And for SARS coronavirus, we know that this virus has been able to become endemic in minks, which then were able to transmit back to humans, and those mink populations were culled. So we don't have a good prognosis for eradication of SARS coronavirus 2, and we should not even be speaking about that at present. But there could be a vaccination strategy unique to coronaviruses if the proper research is done. This is some research that was done after SARS in 2003, and you can see that 80% of animals from one animal market in the Guangdong province contain significant levels of antibody to SARS coronavirus. At the same time, looking in communities around the markets and at market workers, it was found that 13% of animal traders had coronavirus antibody compared to 1 to 3% in the surrounding areas in the population living in those areas. So there may have been a strategy to develop either vaccinating animals being raised, wild animals being raised domestically in China, or vaccination of market handlers to make sure that they didn't become infected. This was not done, however, but it may be something that could be done with SARS coronavirus 2. So what's the future? We have COVID-19 vaccines. New vaccines are being developed. Existing vaccines will be modified as required, and we know that the mRNA vaccines can be modified very easily. We know that correlates of immunity are not yet fully understood, because of the T cell interaction with the antibody production. So we don't know exactly what the correlates of immunity are, but we have excellent vaccines. We're very fortunate to have those vaccines today, and those vaccines can be used for personal protection against serious illness and death. They provide greater safety in closed indoor and outdoor gatherings, safer travel, and slower development of variants, as we've seen. But we need to make sure that there's more equitable distribution of COVID-19 vaccines. For influenza, there were some intergovernmental groups that began to meet back in 2007 that developed the Pandemic Influenza Preparedness Framework, which actually assures that companies will provide vaccine to WHO at the time of an influenza pandemic. They will donate vaccine to WHO, and they will also reserve vaccine that WHO can be purchased at affordable prices. We have a model that's followed on to this, which is the ACT Accelerator, which is attempting to increase research and development on vaccines, diagnostic tests, and therapeutics, but also is making them available in countries. And the COVAX facility of the ACT Accelerator is attempting to make vaccines available worldwide. You can see here an early graph showing which countries are partnering, either now or intend to participate in the COVAX facility. And this is very important and vital that we get the vaccines available to countries, and so that countries that want to use these vaccines can get them through a facility which either provides them at no cost for their health workers, for example, or at a lower cost if they want to use them for their general populations. But there's one lesson that we need to learn, and that's about smallpox eradication. Smallpox disappeared and was certified eradicated in 1980. In 1981, HIV was first identified, and today we know that HIV is a very important infection throughout the world. However, in 1984, a military recruit in the US was vaccinated with smallpox vaccine. He developed generalized vaccinia. He was HIV infected and not known to the vaccinators, and this was an AIDS-defining event. We know today that the vaccine used to eradicate smallpox could not be safely used in the world, and we would have a very difficult time eradicating smallpox using that vaccine today. So the lesson is that we need to use the vaccines that we have, especially the COVID-19 vaccines that we have today, to make sure that we use them in the right way and protect people from serious illness and death. Thank you very much. I'm sorry I couldn't be with you, but it's been a privilege to speak with you in the plenary.